He's joining in a couple of minutes.
We'll start, but we'll start.
Yeah.
We are very tightly placed.
Yeah, it's over to you, sir.
Yeah. On behalf of Indian Sepsis Forum and with support of World Sepsis Meeting, we are holding this annual meeting. The size of the meeting has been downscaled, and this is the first time that on World Sepsis Day we are having an online meeting. We have a whole starcast with us, subject experts. We'll start with the video address from Dr. Carlos, who is the chair of World Sepsis Meeting. Dr. Charudat Arora, who is at Gurgaon. He is a critical care and ID specialist. He will be our scientific coordinator for the evening. Over to you, Dr. Charu.
Thank you so much, Dr. Yash, sir. Appreciate it. On the occasion of the World Sepsis Day 2020, and on behalf of the Indian Sepsis Forum, I welcome you all to the online symposium on sepsis and COVID, which is presented by Bharat Serums and Vaccines Private Limited. Just an overview of why is it important. Everyone is a stalwart and a knowledge expert in the area, but why are we having this online symposium on the occasion of World Sepsis Day is because of the high gravity of situation about sepsis. Sepsis is a global health alliance. It's a crisis, which generally affects more than 50 million people every year. At least 11 million people die, which counts for 1 death in every 2.8 seconds. And the rate of mortality can even go up to 50% depending upon the location of the person. About the Indian Sepsis Forum, it's a conglomeration. It's a global organization which was founded in 2016, August, just to reduce the burden of sepsis and the guidance of stalwarts in the field of medicine, critical care, and infectious diseases. It is one-of-a-kind organization which is solely based on the practice for the management of patients with sepsis. The aim is one and only one: better patient care, better clinical outcome, and to practice evidence-based care. I welcome you all again to the online symposium on sepsis and COVID presented by the Indian Sepsis Forum. Now we can have the welcome message by Dr. Carlos Sanchez, who's an MD, education from Venezuela, also from Cuba, currently working as a leader in COVID task force and organizing committee member of World Sepsis Meeting from Ecuador.
Just a minute, sir. I'm sharing it. 1 second. I kept it on, but facing a challenge. 1 second, sir. Just a minute, sir.
Yes.
Something else is hanging up my system. So,
hello, everyone.
Yeah.
Perfect.
Hello, everyone. I hope you'll be okay. Thank you very much for this kind invitation. My name is Carlos Sanchez. I'm an intensive care specialist. I'm Venezuelan, but I live in Ecuador. I'm the program chair of the World Sepsis Meeting and founder of the Proyecto Sepsis Ecuador. So now let's talk about sepsis and septic shock in a few minutes. First, how big is this problem? As you know, more than 50 million of people develop sepsis around the world each year. And 11 million of that people die. That is 1 death every 3 seconds. In the most countries, sepsis kills more people than cancer. Even when we talk about maternal sepsis, 261,000 of women died every year. And we interpret this death as maternal deaths caused by sepsis. And this number is rising even in countries as United States. But the problem is not just the sepsis. It's what happened when the patient is discharged from the hospital. So, as you know, the most patients could suffer from sadness, difficulty to swallow, weakness, muscle weakness, confusing thinking, difficulty to rest, memory problems, concentration problems, anxiety. How do we diagnose sepsis? So, according to this, the third international consensus definition for sepsis and septic shock, published in the year 2016, they give us new tools to diagnose sepsis. And it's very important to know if the patient that we are helping is in critically or not critically areas, yeah? Because we will use different scores. If the patient is in probably the emergency room, the ICU or post-surgery room, we should use SOFA score. But if the patient is in a regular ward, Q-SOFA or quick SOFA should be the best scale for these patients. Yeah, you know, if the patient met two criteria from quick SOFA and suffer from an infection, he will probably develop sepsis. And if when we use SOFA score, if the patient have two or more new points and suffer from an infection, he will probably develop sepsis. And it's very important to know that he will probably develop and not that he now is suffering from sepsis. And what are the most common causes of sepsis? So infections in soft tissues related with catheters, urinary infections, pneumonia, intra-abdominal infections. And now, what's the difference when we talk about the definition of sepsis and septic shock? So, when we diagnose septic shock, the patient must have an infection and suffer from hypotension using a vasopressor to maintain their blood pressure, median blood pressure, equal or greater than 65 millimeter mercury, and the lactate levels must be elevated. So both criteria must be present. But now the question is, how should we treat patients with sepsis or septic shock? So as preference, it should be in the emergency room or the ICU, because sepsis is an emergency, and as the emergencies, sepsis kills. If we don't give the ideal treatment to each patient, they will die. So in the ICU, we have many people, trained people, we have machines, and everything that we need in most cases. According to the Surviving Sepsis Campaign guidelines, we should give fluids, and this is a very debating point, because not all the patients really need fluids. But if we decide to give fluids, we should guide our resuscitation using dynamic hemodynamic parameters, yeah, and to give crystalloids. What about vasopressors? As we know, septic shock is a vasodilatory state, and we should give vasopressors as soon as possible, even if we're not giving fluids. What about antibiotics? They're very important. Always then, the sepsis or septic shock is caused by bacteria. Remember that not all sepsis and septic shock are caused by bacteria. So according to this, maybe we could have a new approach about how treating sepsis or septic shock, based in three things: vasopressors as soon as possible, fluids if needed, and antibiotics as soon as possible once we decide to give them. Yeah, it's not necessary that it be in the first hour, because this could conduce to a mistakes in the diagnose moment. So thank you very much. Hello everyone, I hope you'll be okay. Thank you very much for this kind of.
So thank you so much. That was the message from Dr. Sanchez from Ecuador, and also, as I said, that he's the organizing committee member. He's a chairperson for the World Sepsis meeting, which is ongoing. Am I audible to everyone?
Yes.
Now, before we start our discussion for the World Sepsis on the World Sepsis Day for the online symposium on sepsis and COVID, I'd like to introduce the chairpersons for today's meeting. They don't need any introduction per se. And as Dr. Javeri said, Dr. Rangappa sir is actually, he's busy in a family commitment, so he'll be joining us soon. But just as an introduction, Dr. Pradeep Rangappa, he's a consultant in ICU and currently working with the Columbia Asia Group of Hospitals in Yeshwanthpur. And also we have one of the fathers in the critical care medicine, Dr. Abdullah Sansari, who's the director of the critical care at this Nanavati Super Speciality Hospital in Mumbai. Now moving to the first part of the symposium, that is open discussion on sepsis and COVID, same but different. It is being held by Dr. Yash Javeri sir, who's currently heading as a critical care head and anesthesia and emergency medicine head at Regency Group of Hospitals in Lucknow. He's also known as one of the leaders in critical care in India and renowned worldwide, who he actually works towards high quality evidence-based medicine in critical care. He's also the convener of Indian Sepsis Forum and the vice president of the Society of Neurocritical Care. So here to Dr. Yash Javeri sir.
Thank you, Dr. Charu. Am I visible? My slides are visible, and is it audible, clearly audible?
Yes, sir. Please go ahead.
Okay. So I'll give a small presentation, then we'll have some question and answers on the same. I'm going to discuss sepsis and COVID-19. What are the similarities and what are the differences among these two? It was said by Sir William Osler in 1904 in his essay on evolution of modern medicine. Except on few occasions, the patient appears to die from the body's response to infection rather than from it. This holds very true for sepsis, and it holds equally or probably more true for COVID. The patient is not dying because of the viral replication. The patient is dying because of the physiological perturbations which are induced by the viral replication. So the trigger in COVID is the coronavirus, the inflammatory trigger, the infectious trigger, but the immune response, the host immune response is more deadly, and same applies to sepsis. So they are quite similar in a sense. The agenda of my presentation will be to understand that the global burden of sepsis is continuing to challenge clinician in its definition, diagnosis, and treatment. We all know this. The current COVID-19 pandemic seems to have almost taken our understanding of the sepsis syndrome back decades, and we are revising our learnings from sepsis. What all we have learned in immunopathology on sepsis, is being applied to COVID. The pathophysiological and therapeutic options for sepsis in COVID are being explored, and we are trying to understand what is the similarity between current COVID pandemic and sepsis endemic. Sepsis is endemic worldwide, whereas COVID is pandemic for now. We don't know whether it will become endemic in the long run. And we'll see from today's discussion what all we can learn from the similarities or differences between these two. Sepsis is a clinical syndrome, and so is COVID. We have not been able to define sepsis very precisely as of now. We could not categorize disease sets. Same applies to COVID. There is no holy grail for diagnosis or for therapy. At least for COVID, we have a simple test where we can diagnose with good certainty if our lab errors are decreased. COVID-19 in its clinical form might show a whole spectrum, but those serious are in sepsis bracket. The spectrum could be from asymptomatic to GI manifestations, could be simple sore throat or fever, but the critical one or the serious one are generally in the sepsis bracket. They have similar presentations. There have been various things and therapies which have been described in medical press, which might not be very evidence-based. So we will try to analyze those facts also. History, the medical history over last 40 years, the research which has been done in 40 years has been trying to be replicated in last 6 to 7 months. It might be for therapeutic options, it might be for vaccine, it might be for diagnostic modalities. So everything has been fast-tracked into 6 or 7 months. This is the essence of sepsis: infective stimuli, immune system, and the physiological effects. Same happens with COVID. Stimuli is the virus, but with great immune dysfunction or immune disarray, there is also a very hugely thrombotic state. Thrombosis do exist in sepsis also, but is it of the same extent as in COVID? We probably don't know as of now. But as a class, if we say COVID-induced sepsis, it has much more thrombosis than a bacterial sepsis of same severity. So the lines between COVID-19 and sepsis can be very blurred, and there is a lot of overlap between pathophysiology and treatment of both. Going on to pathophysiology. COVID is both a sepsis syndrome, but it also has its unique flavors. Much of pathophysiology is very similar, but endovasculopathy, endovasculitis is little different from sepsis, and small vessel thrombosis, which can happen anywhere in the body, is also quite peculiar to COVID. This is the classic inflammatory cascade which we see in sepsis: a pro-inflammatory followed by anti-inflammatory. There are serial inflammation theory, there is parallel inflammation theory. Some patients may have persistently inflammatory state, some patients might have persistently immunosuppressed state, and these two phases, especially persistently immunosuppressed phase, is primed to get a second hit. The model of inflammation is quite similar in COVID, although the timelines could be different. There are pro-inflammatory phase, there is SCARS phase, and the SCARS phase is followed by or is overlapped by a phase of huge immunosuppression where the patient is at risk of secondary infection. So the clinical phases of sepsis: pre-sepsis, acute phase, and then recovery phase, and post-sepsis syndrome, POPICS what we call. And we have a similar picture in COVID. We have a pre-symptomatic phase, we have a phase of acute illness, and we could have a prolonged recovery phase. It could go on for months. We all are trying to learn that post-COVID sequelae could also run into months to years. So is the immune responses in COVID-19 is a mirror image of sepsis? It holds very true. There are many similarity in terms of humoral or cytokine cascade which is involved, the immunosuppression which follows. So there are many similarities, but there are inherent differences also. The timelines are not very well defined in sepsis. Some patients might not land into an acute phase of sepsis even after weeks of infective insults. Some might have a severe disease, some will have less severe disease, some will resolve very, very fast. And it is dependent on many factors like coexisting disease, cause of infection, type of infection, site of infection, we all know that. Similarly, in COVID, the timelines are still not very well defined. The incubation period itself could be very, very variable. The initial stage of infection could vary. Progressive phase of infection could vary, and the resolving phase of infection could be also of any duration. So the timelines are blurred in both sepsis and COVID. So prediction is difficult, that which patient will have severe disease, which patient will recover at what time. We do not have an immunometer, we do not have a holy grail to diagnose sepsis, we do not have a holy grail to diagnose immune dysfunction in COVID. Host response is unpredictable in both, and it is the host response which decides the severity. It is the host response which decides the outcome of the patient. COVID-19 is a dynamic disease. However, we will need to study patients at different stages of the disease to identify predictive factors and appropriate targets for therapeutic intervention. A single picture of cytokine levels or cell population distribution or other markers of interest would give us only a partial idea of an evolving disease. It will give only a snapshot at a particular time. But we have to study these processes dynamically. Sepsis is followed by a phase of immunosuppression. Initial hyperactivation is followed by a phase of immunosuppression. We all know this, which is a defective innate and adaptive immunity response, generally followed after 7 to 8 days of SARS. Similar picture is seen in COVID also. After hypercytokinemia, overexpression of TNF, interleukin 6, 1 beta and 2, which is the early phase of disease, is followed by an obvious depletion of these cytokines. There is obvious depletion of lymphocytes, which has been demonstrated in COVID as well as in sepsis. Exaggerated innate response followed by an inappropriate switch to an adaptive response, which is a phase of immune system exhaustion. This happens in sepsis. This happens in SARS-CoV also. This is an imagery of cytokine storm. There is a lot of discussion about cytokine storm in COVID. We'll see what are the similarities in cytokine storm in COVID and sepsis. Severe and mild COVID-19 has demonstrated all cytokines reach their peak serum levels 3 to 6 days after disease onset. IL-6 levels, however, began to drop approximately 16 days later, and IL-10 levels were at their lowest 13 days after the disease onset. The cytokine levels reached similar points for all patients with severe and mild disease 16 days after disease onset. The IL-6 levels in COVID ARDS, in COVID sepsis, in COVID cytokine syndrome is not as high as in other viral pneumonias, other viral ARDS, or other causes of cytokine storm. So these levels are high. IL-6 levels are at lowest 13 days after disease onset. The similar dynamics is seen in all cytokine storms or all viral ARDS, but the levels of IL-6 are still not as high as in other viral influenza or other causes of cytokine storm. This is a picture depiction of the same. If you can see the IL-6 levels in COVID, there are 5 studies in this. And if you compare it to other ARDS causes, you can see IL-6 level 7, 7, 45, 21. And if you see this bracket, alveolar effect, IL-6 level 154 and 86. The levels are much higher in other causes of viral ARDS or viral cytokine storm. Sepsis research is often called as graveyard of clinical research because we do small data analytics, we do large trials, multicentric trials, and the big data fails to show any survival advantage. There are various reasons for the same, but should we be following same mistakes in COVID? Probably I'm not the right person to answer. Should we try and fail and relearn? Should we be following big data analytics blindly, or we should have our own yardstick to measure the outcomes? Drugs now at present to treat sepsis which are licensed by FDA or any authority are zero, and same applies to COVID except for steroid. We do not have any specific immunomodulator for treating COVID. Definition of sepsis, we all are aware, is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Same happens in COVID. The definition, the first on the left side is sepsis, and this is COVID. Syndromic, yes, infective trigger, sepsis could be anything. Here it is virus, immune dysfunction, huge immune dysfunction in COVID. Organ dysfunction might not be there in mild illness of COVID, but in severe or critical or moderate illness, there is organ dysfunction. Sepsis and COVID both are dynamic disease processes. The presently accepted definition of sepsis can verbatim be applied to COVID, except that mild illness or asymptomatic carriers will have no organ dysfunction. Sepsis is still difficult to define. Classic cases of florid sepsis, anyone can diagnose, but majority of sepsis cases, the diagnosis not obvious, the clinical signs are not obvious. Same is the clinical picture of COVID. Majority of cases with clinical presentations which are very, very classic of COVID will be diagnosed easily by clinical diagnosis only, whereas vast majority which are asymptomatic or mild could be easily missed. So there is increasing pressure for widely deployable consistent definition of sepsis, and I think there should be a definition for COVID also. I could not find one as of now. Sepsis, there is statistical problem. We start from infection, we start from generalized inflammation, we start from generalized inflammation going haywire. So the data sets are not, the clinical data sets are not very, very precise. They are not very, very defined. There is a lot of overlap. Same applies, or probably it is more so in COVID. There are asymptomatic, mild, moderate, severe critical disease, and then there is ARDS that again is categorized into mild, moderate, severe. So severity and disease process could be variable both in sepsis and COVID. QSOFA, can it be applied to COVID? We are trying to have early warning scoring system for COVID because our ICUs are overburdened and we are taking care of many borderline patients who ideally should be in a HDU or ICU in general wards. So we need to have some scores or early warning score which can help us catch these patients early. But QSOFA, even patients who are having respiratory failure, the QSOFA score could fail to rise by even 1. So it cannot be applied, and we have to look for some other early warning scores. In the beginning, when COVID just arrived in India or probably in other countries, and the clinical manifestations were so varied, sore throat, cough, fatigue, GI symptoms, fever, headache, stroke, MI. So we were always thinking, could it be COVID? As we were thinking for sepsis. Any organ dysfunction, we always thought, could it be sepsis? And this is again applied not only to acute COVID illness, but also for patients who are now presenting with this long COVID disease. This is a classic animation which we are all familiar with for COVID. Mild cases 80, severe cases 20%, critical cases 8%. The picture is not similar in sepsis. This patient is having sepsis. Most of them will be in severe category, and few of them, about 30 to 40%, might reach critical category depending on the clinical context. But is this similar in all causes of viral influenza or viral ARDS? No, it is not as similar to other causes of influenza. These subgroups of severe and critically infected patients are larger than those observed for influenza infection. So it is probably much more severe than regular sepsis, and it is not like influenza like we were discussing in the earlier days of Biomarkers. This is just an influenza. Many public health experts were trying to downplay the disease burden and probably trying to specify the common man that is this just an influenza, but it is not just an influenza. So we have to be very, very serious about it, about prevention and about treatment. Mortality in COVID is generally due to respiratory failure, but sepsis also contributes. In fact, sepsis has been observed in nearly all disease patients in many of the reported cohorts. The sepsis figures were not always related to bacterial findings in the microbiological workup, suggesting the virus as the etiological agent causative of sepsis. So the viral sepsis can happen in COVID. Direct viral induced tissue damage, systemic cytokine storm, or synergistic effect of both contributes to multi-organ dysfunction syndrome in COVID-19. These are the early warning scores for COVID. We have to deploy them, especially while we are treating a huge population and our ICUs are almost reached full capacity. Can COVID-19 cause sepsis? The answer is yes. While viral sepsis is a possible complication of SARS, viral infections alone generally do not cause sepsis as frequently as bacterial infections do. And if a virus causes sepsis, the physiological repercussions are not that overwhelming. From information presently available on clinical cases of COVID-19, it appears a small percentage of COVID-19 infections can result in such organ dysfunction and death, which is seen in sepsis. COVID-19 may lead to sepsis due to several variables, including direct viral invasion, presence of bacterial or viral co-infection, and or the comorbidities of the patient. About 2 to 5% of patients with COVID-19 develop complications as sepsis and septic shock. The data is hugely variable. Some case reports have shown it up to 50%, some have shown up to 75%. So we need to have a definitive clinical context of calling it as COVID sepsis. We still do not have those definitions, but sepsis happens in COVID-19. It could be because of virus itself. It could be because of secondary bacterial infection. This first case report is from Seattle. 30% had evidence of liver injury and 75% has evidence of depressed immune response. Another study from US, almost 20% of affected patients required ICU care. Septic shock, severe enough to require drugs to support the heart and circulation, is required in about 70%. This is again from the Seattle study. But the shock, is it because of sepsis? Is it because of the myocardial effects of virus, or it is iatrogenic because of the large amount of sedative or muscle relaxants which these patients are receiving? So this is a Lancet report which was published from Wuhan, the earliest of the reports. 59% patient had sepsis of 191 patients in Wuhan. And similar data was available from other countries also. The characteristic of sepsis in severe COVID-19. There are some differences, especially if we talk about coagulopathy. It is much more pronounced in COVID than in sepsis-induced coagulopathy. In bacterial infection, a violent inflammatory cascade often is followed. However, early invasion of COVID does not cause an obvious inflammatory response. There are various hypotheses why this does not happen. One is because of concealment of antigenicity until it is replicated in huge numbers within the cells and then it is released. Then it causes this inflammatory cascade, overwhelming inflammatory cascade. Otherwise, it is an indolent process. It creates an incubation period different from common bacterial infection and has a relatively chronic course. However, if the virus is explosively released, it must appear the violent inflammatory cascade, which might explain a phenomena posed to many of us that few patients seemingly stable might suddenly deteriorate and die within a very, very short span of time after presentation to the ED or the ICU. Endothelial dysfunction is much more pronounced in COVID. Unlike sepsis, in the case of COVID, the pathogen itself proceeds unabated by any currently proven treatment. Remdesivir is the drug which has the largest body of evidence, but the viral clearance is still not as pronounced and as precise as with other antibiotics for bacteria. So the viral replication and source control is difficult in COVID. This means we need to have a two-pronged approach in COVID-19 research. Strategies purely aimed at combating the virus, the antivirus. Strategies aimed at applying sepsis lessons to the pandemic response, which is immunomodulation, which is organ support, which is required for a seriously ill patient. Going on to biomarkers, CRP is generally elevated. Procalcitonin could be low to normal unless there is cytokine storm later on, or when the disease is very, very serious, or when there is secondary bacterial infection. Cytokine elevation rates, the dynamics follow a similar trend we have already seen. D-dimer could be an acute phase reactant, which shows the degree of inflammation as well as the degree of thrombosis. Again, there is no holy grail, and we have to follow these biosignature panels. We have to see all these biomarkers in the right clinical context. Going on to epidemiology of sepsis in COVID. This is from the Global Burden of Disease study, which was published in Lancet 2017, I believe. The epidemiology of sepsis. If you see, the overwhelming disease is seen in Southern America, Sub-Saharan Africa, and Southeast Asia. But in COVID, Sub-Saharan belt is relatively spared as of now. Rest of all the world is almost similarly affected. This is the recent most map of COVID density. Sub-Saharan Africa, still the disease density is not as high as if you see in Southeast Asia or in Southern America. The age-wise disease distribution. Sepsis under 5 mortality is also caused by sepsis, huge contribution. Neonatal sepsis again is a major contributor for neonatal mortality. But in COVID, the pediatric population is largely spared. They might be just asymptomatic carriers, and most of them will have very, very mild disease. Not all of them, most of them. And if you see estimated relative risk for COVID also, this is much less for younger population if you compare it with the patients who are into 50 to 80 of age. This is from China, January, February data from Hubei. If you see 0 to 9, the disease case fatality ratio is less than 0.1%, and similar trends have been seen worldwide. Going on to the therapies. Novel sepsis therapies is a large need. Still, we are trying to search the holy grail, but we could not find. This is a meta-analysis which was published in 2008, where none of the modalities could show any therapeutic benefit. This is an overview of first 6 months of clinical trials for COVID-19 pharmacotherapy. The most studied drug, Hydroxychloroquine, out. Ritonavir is now out. Azithromycin has to be avoided. Tocilizumab, the evidence has faded. Lopinavir, probably the evidence has gone. Chloroquine, no evidence. Ivermectin, still there is no definitive evidence. Favipiravir is out. Interferon is out. Remdesivir is trying to float, and we are trying to gather evidence. Whatever evidence we have now is on remdesivir or steroids. So the picture is almost similar to sepsis. Where do we have evidence except for antibiotics in sepsis? It is only for steroids, that too in refractory septic shock. Pathogen clearance. Pathogen clearance is the main outcome determinant for sepsis. Can it be the main outcome determinant for COVID? We don't know the answer, because we don't have a great antiviral drug which can clear the pathogens in a time-bound fashion, and we are trying to learn with remdesivir. Antibiotic works relatively fast. We have definitive answers for most of the bacteria, but antivirals largely, especially for acute illness, we don't have, as a category, we are still not having good antiviral for acute viral illness. So viral replication goes unabated largely. What do we want in sepsis and in COVID? We do not want microbiological eradication. What we want to stop the progression of disease. If there is mild GGOs, we do not want those GGOs to progress. If there is mild oxygen requirement, we do not want that to escalate. Same for sepsis. We do not want the patient to land up into shock. We do not want the patient to land up into ARDS. We do want to control the physiology. We do not want microbiological eradication. The lack of successful treatment and absence of vaccines has prompted the scientific community to explore other avenues. Host-directed therapies such as immunomodulators could be an interesting alternative for treating patients with COVID-19. If we cannot stop the waves, we should know how to serve them. That is the art of personalized medicine. That is what we call individualized medicine. That is different from push and pull marketing strategies. I am not trying to push immunomodulators, but what we are trying to learn is how to learn such therapies very, very judiciously when we have no definitive therapies. This cartoon we all are familiar. This is a painting in Italy where the three heads of sepsis, hypoperfusion, hypotension, and organ dysfunction are being tackled. We follow a similar approach in sepsis or in COVID. We need to have antimicrobials, antivirals. We need to have thromboimmunomodulation. We call it immunomodulation in sepsis. In COVID, we are calling it thromboimmunomodulation. And the third arm is organ support. So we have to target three things: antiviral, thromboimmunomodulation, and organ support. Steroids might benefit, especially in severe category. Other adjuvant therapies, ulinistatin, thymosin, N-acetylcysteine, and many other agents we are trying to learn. Ulinistatin has been used in China, it has been used in Korea, and there is a FDA trial in US also. Telectoferin was tried for COVID, again failed, and most of these drugs has no evidence. Convalescent plasma, immunoglobulin, high dose steroids, everything has failed. Remdesivir has some evidence as of now. So this is the trident approach which we talked about. And if many people are from Bangalore, if you can remember, this is the Trishul which is at Gavipuram. This is a temple near Bangalore. Adjuvant therapies in evidence-based medicine era. This is true for sepsis. This is true for COVID. Sepsis was the largest unmet need 7-8 months back. But now the largest unmet need is COVID. In the world of evidence-based medicine, adjunctive therapies have a very difficult task to prove themselves. Mainly single center or small studies show therapeutic benefit on outcome, but these results are often contradicted by large multi-center trials. This has happened for many molecules which we all are aware of. Nevertheless, from a pathophysiological point of view, most of these therapeutic modalities have a very firm pathophysiological rationale. So you should be using guidelines very judiciously. You have to trust the guidelines, but you have to verify sections. You might verify the guideline sections from other association guidelines, from your colleagues, from your anecdotal experience. So you have to take guidelines with a little bit of salt. Obsessively follow pragmatic protocols to enhance safety. You should always be pragmatic. Whatever amount of evidence is there for or against a therapy, it should not overrule your pragmatic approach. Largely follow other guidelines based on high quality evidence. You should resist slavishly following guidelines based on indirect or low quality evidence. So follow guidelines which are high quality evidence based and have your own experience and have a pragmatic approach, open-minded approach. So COVID is an opportunity to learn. Enormous incidence of sepsis have occurred from a single pathogen. Enormous amount of ARDS or COVID-associated respiratory failure has resulted from a single pathogen. So we have a very homogeneous population to study. single entity, largely similar clinical picture. So we have an opportunity to hone in from research and therapeutic viewpoint. Host response variability could be studied, genomics could be studied, heterogeneity in response, same pathogen, different response. This could also be studied, and this all has been studied. Perhaps if we consider the current pandemic through a sepsis lens, we can avoid making the same mistakes, and we should avoid making the same mistakes that we have made in sepsis research for decades, resulting in no licensed treatment for sepsis. Two-pronged approach, one unique to COVID, and other is revision of lessons which we have learned from 50 years of treatment of sepsis. So the practice points from the today's presentation are: the essence of severe COVID-19 is a sepsis induced by viral infection. What doesn't work for sepsis will probably not work for severe COVID. Is it reasonable to adopt the treatment strategy similar to sepsis, such as immunomodulated treatment? I will leave these questions open. COVID-19, are we treating the wrong disease the wrong way with the wrong attitude? What is the name if we do not want to call COVID-19, especially the severe category as sepsis? If COVID-19 is serious, COVID-19 is same as sepsis, then why are we calling it by a different name? We'll try to understand the pathophysiological response, the hypercoagulability, which is much more severe in COVID. It is unknown whether recovery from COVID-19 will be different from that of sepsis, and the sequelae of COVID-19 has to be studied. We should not be leaving individualized and personalized management of patients. This is again very, very important. These are lessons learned from sepsis and ARDS the hard way, and we should be applying it to COVID also. The most important thing, public health and preventive medicine should be applied for COVID-19, what we could not do for sepsis. Thank you. Questions, queries, and discussion.
Thank you so much, sir.
Yes.
Thank you so much, Dr. Javeri, for such an enlightening talk. I think the key points were definitely very much important. And one of the key points which I would take back home to the hospital tomorrow morning will be on thromboimmunomodulation, because we've been facing that a lot. And that has been one of the most pivotal components of managing this whole pandemic, and especially the severe cases. We received a couple of questions during your talk. I would like to take a couple of them in view of the time constraints. Number one being from Mr. Praveen Dandekar, that what can be the role of oral steroids in early disease of COVID-19?
I'll request Dr. Ansari to answer the questions, please, if you can moderate. Dr.
Ansari. First of all, thank you, Dr. Yash, for organizing such a nice session on the day of the day we celebrate for sepsis, and tell us that we are long way away from achieving our reasonable control on sepsis. And on top of it, COVID-19 has already exposed the weak links in the care, and all of us are challenging at various levels. But one thing is important, it has also brought us together. Nowhere and never in the history of mankind has the whole civilization come together to fight one enemy. And though the number of mortalities have not yet abated well, but I think we all have still put a good unified front. Coming back to the question that how should, actually, I think we are just on a warm-up session. More and more questions will come. In fact, I would want every panelist to put their opinion about this, but I personally feel there are certain very special features of COVID-19, of which very important and paradoxical one is that this is one infection where host response is as strong as what the virus does. Otherwise, nowhere in sepsis would we have a positive trial for steroid, or even a thought process that we can incorporate steroids into our treatment armamentarium. And here, I would be not surprised if people do study with antiviral alone and antiviral with steroids, and will find a definite trend or a signal towards improving outcome with a combination. So I would rather answering it, I would say I am little pro leaning towards usage of gentle usage of steroid little earlier rather than waiting for oxygenation to deteriorate out of hand. But again, that's a hypothesis. I would actually want Dr. Harish and all the other panelists to take it from here. What is their opinion?
Yeah, Dr. Harish here. So as you mentioned clearly, so when it comes to COVID-19, like one hand, like the sepsis kind of this one target what initiated, that is the virus. So currently it is being well elaborated by Dr. Yash also. Whatever available antiviral, that is the remdesivir, little bit some favoring evidence is there. Okay, we'll go ahead with that remdesivir. But on the other hand, like what the host is going to respond in a dysregulated, in an uncontrolled way, so that we have some modulation. That is one therapy which showed a good evidence is the steroid. But when it comes to like starting the steroid, whether it's an oral form or an IV form, there are certain things I want to remind here. So it is then solely on the timing. So just okay, patient has been like accidentally or some sort of symptomatically has been tagged as COVID-19, means like suppose a scenario is like this, means he came for some sort of elective surgery. So nowadays most of the hospital doing their TrueNet or maybe RT-PCR before they proceed. And like if he comes to be positive for COVID-19, so even though it is early, I don't at all recommend the steroid at that moment, means irrespective of his positiveness. So then solely giving weightage to how early or the time in terms of starting the dexamethasone, we have to club together with what severity of the disease kind of this one. Clearly, so many of the patients, those who are like just tagged or like diagnosed to be COVID-19 may not require the steroid at all. Even the evidence also, what we learned from recovery trial, those who are requiring oxygen and like mechanical ventilation, they are the one who are going to require the dexamethasone for some sort of clinical improvement. Saying that, so one mid-level of indication what I want to like emphasize here is, so suppose a patient is like not requiring the oxygen, okay, that is one of the criteria for dexamethasone, but he is having persistently high-grade fever, very bad myalgia, means like other than the oxygen requirement, his other prodrome is very bad, and he has been diagnosed with the COVID-19. So that is one scenario, like I want to give the steroid of 6 milligram of dexamethasone. When it comes to the dosage, it is like all or none phenomenon, means 6 milligram we need, but more than that, I don't think, okay, whether to pour them with some sort of pulse dose or we'll put them as 80 milligram BD, 40 milligram BD. That is something which is lacking the evidence at this current scenario. But definitely, so we have to take into weightage of their severity, non-oxygen requirement of clinical manifestation. So along with that, the time is the third parameter we need to consider when it comes to steroid.
Thank you so much, Dr. Harish.
Yeah, good afternoon, everyone. Dr. Mishra here, actually, from Hyderabad. Just to add something, what Dr. Harish has told. Basically, if you see the recent guideline on steroid, WHO has come out with a guideline for COVID steroid. That is on 2nd of September, if I'm not wrong. What they have told are two things, actually. There are two guidelines. Like one is steroids, yes, helpful in COVID, but in severe and critical COVID only, not in mild form of COVID, where they have discouraged, actually. The first one, steroid is useful, that is strong evidence, and it is useful only in severe and critical, that is a consensual like whatever they have came across. Yes, as Dr. Harish told, people having high grade fever, severe body pains and all, we also start off low dose steroid. But at this point of time, the evidence is towards severe and critically ill COVID patients only. There is a role of steroid. Which steroid? Anything is going to be okay. Maybe dexamethasone, hydrocortisone, prednisolone, or methylprednisolone. The dose should be on the lower side, not on higher doses.
Just wanted to add one thing from Dr. Madhusudan from Hyderabad.
Yes, Dr. Madhusudan, please.
I think just appropriately was mentioned by Dr. Harish and Dr. Mishra. Just wanted to say we have to consider the three things. One is about the clinical symptoms of the patient. second about the history what patient is giving, and you do radiological investigations. I think all this appropriate if you take the proper things of the history, clinical examination, and radiological investigations, because most of the patients are doing CT scan. I think that will give an appropriate way when to start medications for you. Thank you.
Thank you so much, Dr. Jaju. We'll take one more question before we move to the next session. The second question is by Ms. Parul, who is asking, what are the indications of tocilizumab in COVID-19 infection? Can I ask Dr. Javeri sir to please answer this?
I think let Dr. Ansari take the questions.
Dr. Ansari sir,
Dr.
if you
Ansari?
are, if I'm audible, can you please take
Dr.
this question?
Ansari and the moderators. Yeah. Dr. Harish, are you around? Okay. I think we have lost connection. Okay. Tocilizumab has to be initiated when there is cytokine storm. The cytokine storm could be diagnosed by clinical picture, but rising IL-6 levels or other markers of inflammation should also be there. Is tocilizumab going to save lives? The answer is still not clear, and the answer is probably no. So if you want to use tocilizumab, you have to use once you have cytokine storm, which is evident by worsening physiology and worsening clinical parameters and the biological parameters. But is it going to save life? The answer is probably no. Dr. Harish, your take on tocilizumab as of now.
Yeah, tocilizumab is something in the initial era of this pandemic, we also poured to many of the patients. So like I had like lots of problem with the therapy also. Couple of patients had a severe marrow suppression post tocilizumab, and like when we consider some sort of indication also, lots of things we have to negotiate. Okay, so procal should not be very high, there should not be 100% surety, no bacterial infection, no active TB, no active hepatitis, WBC should not be less than 3000, platelet should be more than 80,000, kind of this one. So after considering all these things, okay, what we are targeting by giving the tocilizumab is only one marker, that is IL-6. But we already learned from Dr. Ash lecture also, and we already know it is not only the one pro-inflammatory cytokines which is creating the problem. We have an array of like cytokines. It may be IL-1 beta, TNF alpha, IL-8, IL-2. These are all the pro-inflammatory cytokines. A therapy which is targeting only one marker with lots of relative or absolute contraindication with some sort of like adverse effects, I don't prefer at this moment, because it is very uncertain. It is in terms of experience. When it comes to evidence also, except some, I think last couple of weeks back, we got one retrospective observational data published in Lancet, which gives some hint, okay, tocilizumab have some outcome benefit. But the COVAX trial so showed no much benefit with the tocilizumab and all. So like everyone tried to repurpose, okay, their medication in COVID-19, like that it's happened for tocilizumab and itolizumab also. I personally, like after maybe in the last couple of weeks to a month, maybe 1.5 months, I am not using the tocilizumab at all in my clinical area.
So there is a lot of collateral damage, especially if we are using so many drugs together, especially with collateral, as Dr. Harish pointed out, there's a lot of collateral damage. So some subset of patients where you are very, very sure, you might use it very, very judiciously, but tocilizumab is not standard of care for COVID-19 patients who is having organ dysfunction or sepsis. And probably the incidence of high sepsis is probably contributed and added on because of tocilizumab also. We'll go on to the next presentation and take the questions in the panel discussion. Dr. Charu?
Sure. Sure. Thank you so much. So we move to the next set of the presentation, which is a panel discussion revolving around COVID and ARDS, a glimmer of hope. The moderator for the presentation will be Dr. Yash Javeri, and the panelists would be Dr. Madhusudan Jaju, who's the Director of Critical Care at Care Hospitals, Nampalli. His key areas of interest include mechanical ventilation, ARDS, infectious disease, and post-transplant patient care. Dr. Harish Mallapura, who is a well-known entity. He's a consultant of critical care and anesthesia at Mazumdar Shaw Medical Center in Bomasandra, associated with Narayana Group of Health. Dr. K.C. Mishra, sir, who's a critical care specialist at Care Group of Hospitals, Hyderabad, Banjara Hills, and Dr. Sanjeet Sasidharan, who's a HOD and of critical care at SL Raheja Group of Hospital. And I personally follow him for all of his innovations, including iNutrimon, which is a nutrition, a software for critical care patients. So we forward the discussion on COVID and ARDS, a glimmer of hope, to the panelists.
Thank you, Dr. Charu. I'll start the questions. We have Dr. Madhusudan, Dr. Hari, Dr. Mishra. Dr. Sanjeet has joined. Is Dr. Sanjeet around? Dr. Gunjan,
I'm there.
have you joined?
I'm there.
Okay. And is Gunjan also, Dr. Gunjan, are you also around? Okay.
Yes, I'm there.
Okay, thank you.
Yes.
So we'll start with the first question. I'll pose this question to Dr. Sanjeet. Is COVID ARF, acute respiratory failure pathophysiology, same as the conventional ARDS?
No, it's a very, very interesting and very difficult question to answer in the first place. But yes, it is not as inflammatory as it is in conventional ARDS. I mean, if you look at inflammation on its own, it is not. If you look at biomarkers on its own, it's not as inflammatory as you see in commonplace ARDS that we see. The second thing is this kind of ARDS has got a lot of pseudo ARDS happening here. I mean, if you were to actually ventilate them with the right form of ventilation, looking at transpulmonary pressure and stuff, you might notice that you might be able to recruit much more than other patients that we have on ARDS. So we've been able to recruit a large number of patients. It's very different to look at the speculative theory that Gattinoni said about L going to H and things like that, but it doesn't figure that way. In fact, the Boston and Seattle data that you just mentioned actually said that there is nothing like an H or L phenotype. In fact, when we start with also, we are seeing low compliance. I'm not seeing normal compliance, I'm seeing kind of low compliance, and it kind of gets better when you recruit them. So it's a very different kind of an ARDS that we've seen, and it lasts for much more longer. If it is conventional ARDS, it lasts much more longer than the ARDS that we've otherwise seen. I mean, it lasts for months at stretches, and people are transferred at home at respiratory cripples at times at 2.
Okay, thank you, Dr. Sasidharan. The next question is to Dr. Jaju. What is the role of immunomodulation in COVID, especially in seriously ill or critically ill COVID?
Thank you, Dr. Yash. As you presented there, the thing in the whether the sepsis or COVID, we don't know exactly which medicines are working there. And we are understanding the pathophysiology of the patient in cases of the COVID, which causes the more of the endothelial damage, and what routine medications you are giving, we don't know how the response is there. So that definitely, as we are searching, as you told in your presentation, or in the cases of sepsis, we are searching something else. Definitely the role is there for immunomodulation because we are seeing a lot of inflammatory response from the human body, so that we have to modulate the response. Definitely role is there for immunomodulation. And as your presentation went on, the various drugs are there for using the ulnastatin and thymosins and so on and so forth. Dr. Yash? Hello?
I think we lost Dr. Yash connection. He'll be joining in soon. In the meantime, I can take one question to the panelists, to Dr. Ansari and Dr. Harish. There's a question on what is the role of antiviral in COVID-19 patient till the time we have Dr. Yash joining us back. Dr. Ansari, sir.
So I think, welcome Sanjeet, and I think just kind of taking the question before about ARDS, I think I would just like to emphasize one line, that ARDS conventionally thought was mostly an alveolar process. This COVID-19 has actually exceeded that into some interstitial involvement, which could be variable, patchy, and prolonged. Which means that contrary to the recruitment, which is usually an alveolar process, which you can probably do early on the course, but even if you got a good recruitment, gas exchange is better. Exiting out becomes difficult if there is significant interstitial involvement, which means there is a lot of cicatricial and scarring happening, fibrosis is much more prominent, and residual lung impairment is far more than in a bacterial or a conventional ARDS model. So I think this is where probably a little difference is there. Moving on to the second part about antivirals. So this is the only virus in which we have been giving antibacterial, first of all. So assuming that there will be some kind of associated antiviral activity, and we are questioning the role of antivirals. So I personally feel the antivirals may be not as effective as we want them currently, especially there has been a lot of debate about the efficacy of favipiravir for moderate and severe illnesses. Definitely has not been studied. Remdesivir again has shown variable response, but I think all said and done, we need to have an effective antiviral. There's no question about it. That may be a different issue, that the virus multiplication will not be following the same breaking mechanism like it has in an antibiotic. You may be able to control the replication for a while, but you will not be able to contain it. And the kind of the total structural dysfunction that happens, and the host response becomes much more a bigger driver after the 5 to 7 days. So antiviral, there is no doubt that antiviral will be important and very early in the course. But a few people, or maybe 15 to 20% of the patients, will escape that mechanism where host will drive the whole problem, and the secondary organ dysfunction will actually lead the further clinical trajectory. I hope that answers. So I personally believe antiviral has to be started early on the course for symptomatic individual, whether mild, moderate, or severe. Moderate and severe ones alone, antiviral may not be sufficient. And you need to have immunomodulator, immunosuppressant, and other adjuvant therapies depending upon the extent and the involvement of various organs.
Thank you so much, sir. That was very helpful. I think we have Dr. Yash back.
Yes. So I'll pose the question again. Probably I might have missed a few lines about the discussion. So does early antiviral guarantee non-progression? Dr. Ansari, Dr. Gunjan, and whoever has seen the larger burden of disease. What is your experience? Patients who have been given early antiviral did not progress.
So
the severity was less.
So,
yeah, Dr. Misra.
So I'll take that. So the question is, without antiviral, how many people from mild will progress to moderate and severe?
Yeah.
Now that data itself is so scant that there is no comparison. If you look at that, conventionally people have said that 15 to 20% of people will progress to moderate to severe illness. Now, to show that a large number of cohort of people have been given early antiviral and that progression has been reduced, that signal is there in both the trials. But to say that whether they will stand the test on a population kind of, large population study, I don't think so, because there is so much of heterogeneity and the host factors will be ultimately driving. So the question would be for moderate illness people, if you give timely antiviral, will that stop or reduce the progression, which could be the primary endpoint, into severe illness? Severe illness. So for convalescent plasma, we all know that it may not, and that's what my approach would be. It should be rather clinical, algorithmic driven, rather than only on an agent driven approach.
So, what immunomodulator will be chosen in your practice?
Back once everybody has given an opinion, so it will be good that we have a diverse, let's have a difference of opinion from everyone, and then we can hear out everyone. Maybe Dr. Jaju or Dr. Mishra can kind of give their opinion.
Yeah.
Yeah, can I take that?
Yes, please.
Yeah. So, the question was whether it actually reduces symptom duration. So, on an evidence-based perspective, on a evidence-based perspective.
Yes.
Sorry.
So on an evidence-based perspective, if you look at symptom duration on its own, I mean, if you look at that, there are three drugs. You look at hydroxychloroquine, you look at remdesivir, and we look at lopinavir. You clearly mentioned that these two drugs, hydroxychloroquine, lopinavir, ritonavir, really didn't do anything. But if you looked at symptom duration on its own, I mean, just look at symptom duration on its own, hydroxychloroquine had dropped the symptom duration by 4.5 days. Remdesivir 2.5 days, and lopinavir 1.2 days. Of course, the certainty of these were a little bit lesser. It was highly moderate certainty for remdesivir versus hydroxychloroquine and lopinavir, but that also reduced symptom duration if you ask me for certain. But remdesivir is the only intervention which has kind of moderate certainty. As you rightly said, it's not really well proven. It's kind of moderate certainty compared to low certainty compared to the rest of the drugs. And it remains, because the mortality difference was 7.1 versus 14.1, you know, there has to be some kind of drug that should be added on to remdesivir, which will now drop it further, because we expect a virus to get killed and the patient to get improved. So we probably need a companion drug along with an antiviral, which will probably reduce further length of stay, time to symptom improvement, and probably mortality. Thank you.
Yeah, so we probably need an adjuvant with the antiviral to alter the host response. So I think we all believe that seriously ill or critically ill COVID patients need some sort of immunomodulation. What we will try to understand. And in its simplest sense, steroid is the simplest immunomodulator which we are using as of now. So what phase of illness will you like to start immunomodulation, steroids or other immunomodulators? Will it be in mild ARDS? Will it be in moderate ARDS? Or will it be in severe ARDS? Yes, please. All the panelists. Dr. Harish, Dr. Madhusudan, Dr. Sanjeev, Dr. Mishra.
Yeah,
When will you like to start steroids? We have already discussed. When will you like to start other immunomodulators like ulinastatin, if at all?
Yeah, actually, basically, if you see the immunomodulators which has been studied, or maybe the studies are which are coming up, there are many. Actually, a lot of them that don't have a name right now. Actually, they have only the chemical names. You start with blood products, let it be plasma or immunoglobulins. Then you come to steroid, maybe mesenchymal stem cells, your interference. Then you will have your this monoclonal antibodies like a tocilizumab and all those things. So out of that, I think the few things what I've used already out of like plasma therapy, steroids, maybe we have used tocilizumab in few of the cases. So out of that, the two things what we believe may be helpful, even heparin also has some anti-inflammatory property, unfractionated heparin, not the low molecular heparin. They have tried even a nebulized form of unfractionated heparin. So there are a lot many things are there. So out of that, what I believe have helped, maybe some evidence which are supporting. One is undoubtedly steroid. As per the WHO guideline, when you start steroid, it is at the like severe or critical COVID, not the early part of the COVID, but still we start a little early when the patient is having severe symptoms with CT showing significant involvement of the lung. But still, as per the WHO guideline, it has to be started late. Convalescent plasma, I think the Placid trial has come where it has shown it is not going to help, but you see the Mayo trial, which is more than 30,000, it's an observational trial, Mayo Clinic, where they have done like more than 30,000 people. They have tried convalescent plasma in mild to moderate disease. They have seen good response if the titers are good of the donor. Then if you tocilizumab, again the Rose trial, they have told it is not going to help, but initially we have used in few cases where we have seen some positive response. But Dr. Harish told before, there are a lot of criteria before starting tocilizumab. Akinra, we have not used, maybe that also interleukin-1 inhibitor. There are some data supporting interleukin-1 because that is the first maybe the inflammatory marker which will go to the next cascade of IL-6, tumor necrosis factor and all other things. So many things are there at this point of time. The three things what we use and we have seen some benefit when we are using in patient. One is steroid. Second is maybe convalescent plasma if we are using early. We have data in our hospital where we have seen like it is much more going in together with our Mayo Clinic observational data. Third thing, maybe in very limited cases tocilizumab, as Dr. Harish pointed out, in last 1 month, we have decreased significantly the usage of tocilizumab. Initially, we used to give, but now we have decreased, but still in very selected patients we are using. And we have seen some positive response with tocilizumab also. Rest of the drugs, like still in the pipeline, maybe we need to have some oligrail or something which is really helpful. So those things are still awaited. Yeah,
Yeah.
over to yes.
Thank you, Dr. Mishra. Dr. Harish, what are
Yeah.
your options?
See, basically, when we discuss therapy for this COVID-19, also lots of things are repurposed, like what happened in sepsis in the last couple of decades. Also, from the heparin to the activated protein C, lots of things we have tried in sepsis. That is the same scenario is happening in a large scale for this COVID-19. Heparin, as he told, so the two trials on sepsis, like there was a trial called HATRACE trial, there was a trial called KhyberSep trial. These are the two trials. Basically, the understanding was, okay, it is going to cause some sort of microthrombi because of the endothelial breach. So that will give some sort of heparin to improve the circulation. It is going to have some outcome benefit. But the thought process was proven wrong on the paper when it comes to evidence. So basic, like overall end point in COVID-19 is also some thrombus will be there, some tissue edema is going to be there, some shunting is going to happen. Okay, so then there will be some sort of reactivation injury, free radical injury. So it is almost similar to that of the sepsis. But on the paper, till now, we have only in hierarchy wise a good benefit for steroid. So next, maybe here and there convalescent plasma, and rest of the things you can put together. We are still in a some sort of confusing to get some evidence before we jump on. Okay, this is the conclusion kind of this one. But one other hand, like targeting when it comes to cytokine and all, when we accepted some sort of repurposed medication like tocilizumab, why it is not for ulnostatin? Okay, that is my question. Because see, if you put a theoretical theoretical rationale, okay, we need to target the cytokine, even though we understood now. Initially everyone was jumping, okay, cytokine storm is the well established pathophysiology for COVID-19. After that we had a very good reviews. Okay, this cytokine level, okay, which we got in COVID-19 is a bit less than that of the non-COVID-19 ARDS in the previous era, which we got previous data and all. Okay, even though we need to target the cytokine, so why it is not a pan cytokine target? Okay, like ulnostatin, which is having an approach like serine protease inhibitor after our neutrophil elastase, which is going to release the cytokines IL-1 beta, IL-6, TNF alpha, and IL-8. So if some drug is able to target all the cytokines, why it is not? Because we have some evidence. Okay, not initially we got evidence from the like Indian data only in 2011-12 from Dilip Karnad and all on the ulnostatin in terms of having some good outcome benefit in terms of sepsis patient. And after that we got the data from China, Korea and all those things on the ulnostatin, both in sepsis and ARDS also. Okay, so if at all, okay, we are understanding or we are accepting cytokine, we need to target. First, if you accept that, why not a pan cytokine target, which is the ulnostatin? Okay, so like we have already we have in the initial discussion only, there are lots of trials ongoing on this cytokine targeted therapy by using ulnostatin, even in US, even in India also. We have to wait for that also, but very good theory. If at all, again I am repeating, if at all we accept we need to target the cytokine, why not the ulnostatin? That is one question we need to keep in mind. So the evidence is like evolving, it's coming, good studies are on the go, that we can look in the picture in the array of treating on the one hand, other than this antiviral therapy kind of this one, that we have to understand. So that is my take on other than steroid and convalescent plasma. Like convalescent plasma has already, so it has been told, like even though evidence doesn't show very promising, but we also started using convalescent plasma, and we have put into our ethics starting a trial on mesenchymal cell infusion also. Maybe in couple of weeks we will start recruiting the patients for that study also in terms of non-antiviral target for this COVID-19.
Yeah, if I could just answer this question, thanks for that, Dr. Harish. But if I would just answer this question as to what would be the ideal time to start the steroid, First of all, it's a congratulatory message for all of us that such a large trial. I mean, I think it's probably one of the best, biggest trials ever conducted in critical care against one single pathogen. Against one single pathogen. I mean, we're looking at one single pathogen. Imagine we do the same trial for Streptococcus pneumonia alone. Probably we might see the same results, I feel. Okay, this is just one single pathogen, 6,000 patients, 176 centers. I mean, it's an amazing feat to actually do a trial called as this recovery trial that actually went and said that steroids are working in this case. Of course, it's got its own implications because of the fact that it was open labeled and it was 2:1 randomization and a lot of other things that came on along with recovery trial. But this is also a subgroup analysis, and if you ask me for certain, the mortality benefit seems to be too good to be true. When is the last time you've heard mortality benefit in sepsis? I mean, it's something of a single drug causing mortality benefit. It's something we've not seen for a very, very long time, and we just love to hear mortality benefits. That is such significant mortality benefits. But if you ask me this question as to when would I start the steroid, looking at this study, because this is where the evidence lies, we are looking at. It's probably, if you started early in the course of the infection, immune activation is something that is required. So don't start it early. You require immune activation to begin with. Okay, and it is later on when the hypoxemia sets in that excess inflammation becomes harmful. I mean, so you can't really start it early. You have to start it somewhere late. And if you look at the ideal timing, it's probably the time when the patient starts requiring oxygen. Probably that's the time you'll require. That's what the trial said. In fact, it clearly had a signal to harm if you started when the patient didn't require oxygen. So if you have harm, I don't think we should be going and doing it. So just prior to just the time when he starts requiring oxygen, I think probably that's the time we should hint on starting giving steroids.
Thank you, Dr. Sanjit. Going on to the next part of the discussion, I think many of the panelists have been using uristatin for COVID ARDS. I like to know their experience and what dose they are using, because in the Shanghai protocol, the dose was much higher than we have been using traditionally for sepsis. It was 2 lakh unit BD what we use routinely for sepsis. But for the Shanghai protocol for COVID ARDS, it was about 6 million unit 3 times a day. So what dose have you been using and what has your experience been like, all the panelists? Yes, Dr. Harish, Dr. Sanjeev.
Yeah, so we have started using as a part and parcel of like involved in the study part and otherwise of the study also. So my dosage in terms of uristatin is 2 lakh international unit every 8th hour for 5 to 7 days kind of this one. When it comes to indication, like it should be more than a mild, less than a severe case kind of this one. So don't expect some patient is too severe, is like requiring 100% of oxygen with a PEEP of around 10, 12 kind of this one, difficulty in struggling ventilation. That is may not be always in COVID-19 patient, but is like requirement is very high and with some sort of already compromised hemodynamics with other organs involved and all, means too sick patient, don't expect, okay, you give uristatin and it will make some magic kind of this one. Definitely it should be more than a mild, okay, less than a severe kind of this one. So mild more towards the moderate, severe more towards the moderate. That is the patient where I want to use the uristatin. The dosage is 2 lakh international unit 8th hourly. But if you ask me, I had any outcome data on the paper, we need to wait because I'm one of the principal investigator for the study also. So we are putting the data. So it's like if you see the study protocol and it's like approach is very stringent and it's very good. So we have to wait for the result of this trial. But in off the study also, we are using 2 lakh international unit every 8th hour for 5 to 7 days of the dosage.
You brought the discussion to a very, very interesting point. Timeliness. Like we talk about intubation in COVID ARDS or respiratory failure. When to intubate? It should neither be too early nor be too late. It should be timely, what we are discussing. Similarly, all the therapies have to be time bound. We have a window of opportunity where the things works best. If we use adjuvant therapies too early, obviously most of those patients are going to improve by themselves. We are just adding cost. If we are too late when already the patient has been on 100% FiO2 and prone on invasive ventilation, again, we are too late. So we have to be in the right frame. How to know this right frame is probably more an art of medicine than science of medicine. And the clinician who is at the end of the bed is the best judge to know what is the right window of opportunity. Still, how we know is gradually increasing oxygen requirement, patient landing into sepsis or shock, the inflammatory markers going on suddenly high. Probably this is the subset of patient where we will like to initiate the therapy. And the oxygen support, suppose the patient is on 4 liter oxygen support and in next few hours the oxygen requirement goes up to 10 or 12 liters. That is probably the right window to give such therapies. So Dr. Harish, you used 2 million TDS, which is the dose which we have mentioned in the protocol to the CTRI also. And many of you might be contributing patients to that phase 3 trial. Dr. Sanjit, what is your take on the dose and on the duration of ulinastatin for COVID ARDS?
All right. So when, as Harish clearly mentioned, that he's not been using tocilizumab for a very good long period of time. Even I fell out of reputation of using tocilizumab because of the fact that most of my patients were kind of getting very ill after tocilizumab. That's in the early part when we were loaded. We used to give tocilizumab to these patients, and we kind of completely stopped using it of late. We are hardly using it. But I have a very close friend of mine who actually looks at ICAM and endothelium 1 abroad in decompression sickness. So he actually figured out that if you use ulinastatin, this is a story that I actually got some time back from my friend, and when he used it for decompression sickness, which is very akin to oxidative injury, there was a tremendous drop in the ICAM endothelial levels, as well as 81 and IL-6 and IL-1 and things like that. And he used to regularly give his patient 150,000 units of ulinastatin to these patients, and they did well. So I am also following that kind of a protocol where if my patients are reasonably sick, not very sick, I first give them 800,000 units of ulinastatin to begin with, and then go on with the 2 lakh TDS for a period till he requires, till his oxygenation actually comes to levels where I can put him on a Hudson's mask or things like that. So it goes on for a fair bit long time, almost 10 days to 11 days that I give ulinastatin, but I do start it with a very large bolus, and I'm not seeing any problems with it.
Dr. Mishra, the dose and the duration what you have been using?
Now, most of the ICU patients, like as Dr. Harish told, most of them will be requiring oxygen, or some of them will be requiring NIV or HFNC. So most of those patients we are starting off, the dose is same, like ulinastatin of 2 lakhs 3 times a day. And the duration is not specific, usually 7 to 10 days what we are targeting. If the person is recovering before that, we are stopping it little early, but usual duration is around 7 to 10 days. If you see the studies also, I think there is a small study which was published in China in April in COVID patients. They have done in severe cases actually. They have used very high doses, almost 10 lakh units 3 times a day. Even you see the China, there is a, I was going through, there was a meta-analysis. There was like 38 randomized control trial, ulinastatin in ARDS per se, not in COVID ARDS, in ARDS. There also, if you see the doses, that ranges from 6 lakh 3 times a day, 8 lakhs twice a day, to 2 lakhs 3 times a day. So ulinastatin is first thing, looking at those doses, at least one, it is safe. It is not causing much of harm. Maybe Dr. Sanjit told we can start with a higher dose. Maybe we can go up to a much higher doses than 2 lakh and see if there is any significant, maybe we can see 2 group of ulinastatin itself. Maybe a 2 lakh TID, that's the standard dose. Maybe we can go up to 6 lakh or 10 lakh 3 times a day and see if there is any difference in the outcome in those 2 groups also. Because I believe after going through those studies, ulinastatin is fairly safe, even on very high doses also. So that is what actually we are using at this point of time.
Dr. Jaju?
Sorry, my connection was lost in between.
No
suggested by the ulinastatin, we're using 2 lakh units 8th hourly. Usually my target is there minimum to use for almost 1 week to 10 days. until the disease resolution is there. Sometimes we extended it even to more than 2 weeks also. Regarding the utilization of the medications, only 1 or 2 things we've seen. If you are giving rapid bolus, you'll have some form of hypotension reaction that you have to give over a period of minimum for 1 hour is important thing. The other thing also for the patient, sometimes we used even the higher doses in cases of pancreatitis, even the 3 lakh units or 4 lakh units. What I understood, depending upon the dose, the response is there. Either we can increase the dose or increase the duration. Definitely, the benefit is showing for the patient. Either of one, what are the possible things are there?
Dr. Jaju, again, you brought out a very, very nice point. See, the dose and duration will depend on inflammation, the degree of inflammation. If there is more pronounced inflammation, the dose could be higher. If the inflammation process is prolonged, the duration could be higher. So the dose and duration depends upon the degree of inflammation. Going on to ulinastatin, the indications for COVID could be COVID ARDS, moderate to severe category. Cytokine storm, the Indian IACCM guidelines have put one of the therapies for cytokine storm also, and there have been some case reports of usage of ulinastatin in cytokine storm of different etiologies. And the third one is refractory septic shock, which is the conventional indication for ulinastatin. There have been various trials which have been going on. Sanjeet pointed out about the Chinese trials. There is a Shanghai protocol on ulinastatin. Phase 3 trial is going on in India, and there is a US trial also which is going on from Stanford University, which is a multi-center double-blind clinical study for ulinastatin in COVID-19 patients, which was started in June 2020. So this was the main things about ulinastatin. Dr. Ansari, can I request you to just, Dr. Ansari? Okay, Dr. Harish, will you like to bring out the salient points from the discussion?
See, definitely, when the disease is evolving and like therapies are evolving with a varied outcome in terms of evidence and experience. So one hand, target which caused this, all these, which initiated all this like illness, that is the virus. On the other hand, we have to target what the host is in an uncontrolled way is responding. That is more appropriate in COVID, which is as equivalent to that of the sepsis. In that, definitely we need to put in an hierarchy way in terms of the evidence and in terms of the experience, what I need to use at the bedside. So when it comes to hierarchy in a non-viral targeted therapy, so definitely steroids, okay. So plasma, so here and there. So some therapies, if at all we want to target the cytokine, definitely we can look into the ulinastatin with varied dosage and in an appropriate timely indicated patients. Definitely the hierarchy will go down in terms of tocilizumab, itolizumab and other immune modulating agents and all. But so still pandemic is in the hype, so we need to learn many things from the beginning. At least we are, I can think like we are in the midway of like our experience and evidence in terms of the therapy and understanding the disease itself. So we have to wait and watch. Many of the interventions, many of the therapies which we considered in a robust way, they are in the midway to get some sort of outcome benefit, or so no outcome benefit kind of this one. So basically go ahead with understanding the disease, understanding the therapy and its implication on the clinical outcome. That is the take currently.
Thank you all the panelists, but I will request all of you to stay back, because at around 5 o'clock or 5:10 p.m. we'll be taking the questions and answers after the next 2 presentations. The next one is 20 minutes and Dr. Gunjan's journey as patient will be another 10 minutes. So roughly 5 p.m. or 5:10 p.m. we will taking on the queries from the audience. Moving on to the next presentation, Dr. Charu, can you take on the session?
Sure, sir.
Yeah.
So moving on to the next part of the presentation, we have optimizing outcomes in fungal infection. The speaker of this presentation would be Dr. Amit Mandal, and he's one of the most renowned pulmonologists practicing in Mohali, Punjab. He has around 2 decades of experience currently attached to Fortis Group of Hospitals in Mohali. His key areas include pulmonology, critical care, sleep medicine, tuberculosis, and other respiratory problems. over to the presentation by Dr. Amit Kumar Mandal.
Yeah. Good afternoon, everybody. Thank you, Yash, for this opportunity. And my apologies, sincere apologies that I have not been able to join in live. And you're going to be hearing this as a recorded version. So the topic that has been allotted to me was the optimizing the outcomes in invasive fungal infection. And the way that I would probably take you through would be through a couple of case scenarios, brief introduction on invasive fungal infection, where I'll talk about the different strategies, how we probably employ all of them. And then, of course, briefly a couple of slides on liposomal amphotericin B and echinocandins, and then close it with the guidelines, the practice guidelines from ITSA for candidiasis in 2016. Taking across to the case scenarios, this is a young lady, 37-year-old lady with no comorbidities, was diagnosed with acute biliary pancreatitis, was treated for about 6 weeks in a different hospital before she got shifted to us on dual inotropes with decreasing urine output with high-grade fever. And by this time that there was no culture positivity, she had multiple lines in the background. When she came in, she had a central line, a Foley's line, multiple guided percutaneous drain placements had already been taking place, and of course she had been exposed to a whole lot of multiple antibiotics in the past. This was the CT scan on admission that showed bilateral dense consolidation more on the right lower lobe compared to the left, surrounded along with some pleural effusion bilaterally, some fluid collections around the pancreas as well as in the abdomen. So this is the time that a patient who comes to us in a state of shock with fever, multiple antibiotic exposure, long stay in a different hospital, what empirical antimicrobials, antibacterials as well as antifungals would we probably be initiating in this particular scenario. Move on to the second case scenario. Again, a young lady with fever for about 10 to 12 days with epigastric pain, cough and expectoration for about 6-7 days, associated with breathlessness and altered sensorium. Had the previous hospital had shown that the labs were abnormal with the anemia of hemoglobin of 8.4, a low TLC of 1500, and a platelet of 74,000. She was referred from a different city to our Chandigarh in a private, public sector hospital where she was got intubated in the emergency, and because of a lack of bed in the intensive care, they got shifted down to our hospital. Our hospital labs in the initial go suggested a further decrease in the TLCs of 700 with the platelets of 87,000. That's not 8,700, but 87,000. The PBF, the peripheral blood film, did show activated lymphocytes with no neutrophils. And this was the X-ray with some patchy opacities in the right paracritic region and with some sketchy lesions in the left side too. The CT scan was more probably informative with patchy consolidations bilaterally with some fluffy shadows more on the right lower lobe predominantly. As we went detailed into the case history, we figured out that this patient had been diagnosed about 1.5 years back for a CA tongue, which was evaluated and was planned for surgery, but then they went on to alternative therapy. They did not go ahead with the surgical intervention at that point of time. Ultrasound did show splenomegaly, and we did get a bone marrow aspiration after the history came out that suggested a hypocellular marrow, which was probably aplastic anemia of query drug or query viral induced. We did get septic hyper from the endotracheal aspirate that we sent out. The bronchoscopic that was done did show that the tracheal mucosa had whitish plaques all across, and the transbronchial lung biopsy, which we did with a lot of scare on a ventilator with reasonable PEEP, did show fungal hyphae with branching pattern. And she continued to worsen subsequently thereafter with increasing FIV requirement, with worsening radiology, with lung mechanics, worsening with shock development. And this was the time, this was in mind in 2010 and 11 when H1N1 was one of our major problems. This was the worsening X-rays subsequently that had gone on to show us, and this was, I'll come back to at the end what happened to these case scenarios. Come down to the third case scenario, which was again a young lady with diabetes for the last 10 years, was on oral hypoglycemics but was not on a regular follow-up. Fever with cough and expectoration was ongoing for the last 1 month, which she kept on taking some symptomatic treatment locally. And she came to us with the right-sided chest pain with abdominal pain for about 12 to 15 days, associated hematemesis and hemoptysis about 1 episode before she reached us. She was locally managed in a different setup for about 6 days before and was on broad-spectrum antibiotics. The last TLCs did suggest a raised TLCs of 50,900 with a deranged renal function. She was shifted to us with, and our levels suggested that she had a raised TLC of 23,000, an uncontrolled diabetic status of HbA1c of 13, and there was evidence of oral mucosal candidiasis. The X-ray did show, as you will get to see in the next slide, suggested that there could be a localized lesion in the right mid and lower zone, suggesting that we are either dealing with necrotizing pneumonia or probably pulmonary mucormycosis. Empirically, we did start piperacillin tazobactam along with liposomal amphotericin B. 2 days later, she did get ventilated. The CT did suggest worsening of consolidation and with an increase in the size of the cavitating lesion that was there. We did a bronchoscopy at this point of time, and this is the time that she also had developed shock with organ dysfunction. So this was the CT scan that suggested a localized kind of lesion with areas of necrosis in between, and this is the CT scan more in clarity that you would figure out. This is a large area of consolidation with septal thickening and ground glass haziness in the right lung with few central lobular nodules with three in bud appearance in the right middle lobe with minimum right pleural effusion. So these were the cases. I would at the end tell you what happened and what were the final diagnosis in these scenarios. So just to take it across the invasive fungal infection, introducing the topic, we understand that in the intensive care probably we're dealing with more patients with candidiasis than but of late we've had patients coming across with aspergillosis also, particularly in the background of hematological malignancy or patients who have undergone bone marrow transplant. But in our situation, medical ICU or surgical ICU and in patients who've undergone organ transplant, it's predominantly candidiasis that we would probably see, and that's with the invasive mycosis and non-neutropenic accounts for about 70 to 90% of the candida being the main burden load. This was the CHAM coordinated study by Dr. Chakravarti, Professor Chakravarti from PGI, which talked about the incidence and characteristics and outcome of the ICU-acquired candidemia in India. This was done across 27 medical and surgical ICUs across India. And the overall incidence was about 6.5 cases per 1,000 ICU admission days. Acquisition was early on after admission to ICU and a mean of 8 days. And infecting patients with lower Apache scores of just with a mean of 17, we did, that was the finding from these multicentric study. There were about 39 Candida species which were causing candidemia, and Tropicalis accounted for about 40% of the caseload. And there were some centers which had auris and reversa as the predominating burden, particularly in the public sector hospitals. The azole resistance was to the tune of 12%, actual mortality rates was to the tune of 20%, and the 30-day crude mortality rate was about 44%. The risk factors are all well known. I don't have to probably go into the details, but it's just prolonged hospital stay, prolonged ICU stay, exposure to multiple antibiotics, steroids, elderly age group, diabetes, presence of central lines, immunosuppressive therapy, parenteral nutrition, long-standing or chronic diseases, or probably long-standing hospitalization diseases like pancreatitis, exposure to chemotherapy, renal replacement therapy, malnutrition, multiple site colonization with, and of course, burns being one of the principal factors for where invasive candidiasis could be one of the problems. Now, there are various factors for emergence of Candida non-albicans species, and as all our hospitals, all of us will probably be identifying these more and more often: Candida glabrata, Parapsilosis, Tropicalis cruzi, as well as Guillermondi. And the factors that I enumerated are probably some things like common things like age, malignancies, antibiotics, the exposure to fluconazole, and of course, hematological malignancies, and so on and so forth. Why it becomes interesting and why it becomes problematic for us in the intensive care unit, because these cultures grow late, and if there's a delay in the initiation of the antifungals, the hospital mortality seems to be going up. So if there is less than 12 hours of delay from the time of the antifungals, the mortality is less than 10%, but if it is more than 48 hours, we are almost looking at a mortality of more than 30-35%. And that's why the strategies in terms of trying to use the antifungals, whether it is preemptively or probably empirically, we'll probably, this is where the focus lies in using the antifungals in the best manner. The role of prophylaxis is only probably in the bone marrow or probably the organ transplant situations. And that's the reason why the early antifungal treatment, which becomes the key for a significant reduction in mortality, becomes so important for us in the critically ill patients. There have been multiple algorithms that have been used in the past, particularly colonization index or Candida score or predictive rule, which basically talks about various multiple factors in these patients, and as the score goes up, the propensity or the chances of diagnosing with a patient with invasive candidiasis becomes higher. But the problem with these is that the predictive values are questionable. So the negative predictive value, for if you look at Candida colonization index, the negative predictive value is pretty good at 100%, but the positive predictive value is not so great at 66%. Similarly, for Candida score, the negative predictive value is excellent at about 98%, but positive predictive value is extremely poor at only about 16%, which means that if we follow these scores, we would probably be overusing the antifungals to a large extent. If we use the predictive rules, as I just said, where the, long stay in the hospital with multiple lines and exposure to antibiotics and surgical intervention, again, using the predictive value, predictive rules, the negative predictive value is about 99% and a positive predictive value of just 6%. So these predictive rules, which have been used at one point of time, are very good to rule out the fungal infections, not the other way around, ruling in the infections of fungal infections. So the diagnostic algorithm, which is typically or commonly used by all of us, is if we are getting or suspecting a patient with for invasive fungal infection, one would probably send out the cultures and look at initiating treatment as soon as possible and look at whether the patient is hemodynamically stable. If the patient is hemodynamically stable and has not been exposed to fluconazole, one would probably look at using one of these azoles in the early stages. But if the patient is hemodynamically stable, whether the patient has been exposed to azole or not, one would probably look at initiating echinocandins or probably liposomal amphotericin B, and then subsequently take it forward. So looking across the different classes of antifungals, we have the polyenes, which is the amphotericin B and deoxycholate, or the liposomal preparations. Most of us probably have gone on to using the liposomal preparations. But yes, there are certain situations where we are still using the deoxycholate primarily because the patients cannot either afford or probably the payer does not pay for the liposomal preparations. Azoles, fluconazole, voriconazole, posaconazole, and the isobuconazole, which is just about to be launched at any point of time. Echinocandins, which has probably become the backbone of our antifungal therapy in the current situation. Flucytosine is rarely used probably in the challenge situation with HIV and cryptococcal infections. So this is how the antifungals probably work, with all working on the cell membrane or in the cell wall by interfering with the synthesis of the ergosterol or probably the glucan synthesis. And this is the mechanism as to how the azoles, the polyenes, and echinocandins all act. Looking across, probably the best coverage in terms of covering the yeast, the endemic fungi, the molds, probably the best coverage is obtained with the use of amphotericin, but because of the propensity of the nephrotoxicity, one is, in today's world, one would prefer the echinocandin, which is so safe. And though the azoles also score next in line in terms of the coverage, with posaconazole offering the biggest, almost very close to what amphotericin covers, but the problem with posaconazole is the use in our sick patients where they are not accepting orally and they're probably on nasogastric feeds. As far as diagnosis is concerned, most of us are probably still relying on the conventional blood cultures. Some of the centers all have galactomannan as the facility available, either from the bowel or from serum, but the beta-glucan is probably not existent in most of the centers across the country. The indications for liposomal amphotericin B is primarily severe systemic and or mycosis, visceral leishmaniasis in immune-competent patients, and in presumed fungal infection in febrile neutropenic patients who continue to be febrile in spite of appropriate broad-spectrum antibiotics. And of course, as I just mentioned, cryptococcal meningitis in HIV infected. A point of concern is that one should probably look into the composition of liposomal amphotericin B. All liposomal amphotericin B do not have the same composition, and this is a beautiful paper published way back in 2015, where they had compared the different brands of the liposomal formulations of amphotericin B available in different parts of the world. And they had taken some of the brands from our country. Mechanism of toxicity is primarily dose-limiting nephrotoxicity, which is the principal chronic adverse event. It is caused by vasoconstriction and direct interaction with the distal tubal cell membranes. It binds to the cholesterol in the cell membranes of the distal tubule, which results in the loss of electrolytes, impairing the urine acidification and the concentration, and hence causing the renal tubular acidosis. This is the one which causes the decrease in the glomerular filtration rate and further constricts the afferent arterioles, and which is kind of goes into a spiraling downhill cycle. Echinocandins, which is, as I said, is the backbone in talk about antifungals, and everybody wants to use either the casifungin, anidrolafungin, or maybe micafungin. Pharmacodynamically, they are all, and pharmacodynamically as well as pharmacokinetically, they have the similar response with predominantly oxygen concentrated dependent killing, prolonged post-antifungal effects. They have very similar pharmacodynamic targets. The AUC by MIC target is about 10 to 20, and the Cmax by MIC target is about 1:3. Casifungin has a loading dose of about 70 milligrams, followed by a 50 milligram daily dose. Micafungin, there is no requirement for a loading dose, and one can straight away start either with the high dose of 100 milligram once daily or probably 50 milligram depending on the requirement. Anidrolafungin again needs a loading dose of 200 milligrams followed by 100 milligrams on a daily dose in the infusion. As I said, all three echinocandins do inhibit the fungal growth through a non-competitive inhibition of 1,3-beta D-glucan synthase. They share a similar structural chemical backbone. They have similar effects. One cannot say that this one particular echinocandin is superior than the other, and all the guidelines do not differentiate between the three available echinocandins. Moving across to the clinical practice guideline, which came across 2016. The reason why I've taken up this particular guideline, where it differentiates and presents the way that we would probably look at both neutropenic and non-neutropenic patients in the intensive care. So looking at the non-neutropenic patients in the intensive care, echinocandin continues to be the preferred empiric therapy for suspected candidiasis. Fluconazole can be used in an alternative in patients, to echinocandin in patients who are not critically ill and who have not been exposed to an azole in the background. Here, they need to be loaded with an 800 milligram dose at 12 milligrams per kg, and then about 400 milligrams per kg daily. Liposomal preparation of amphotericin B could be used in patients where they are unable to tolerate the other drugs, and it is used typically in the form of 3 to 5 milligram per kg. Duration should be ideally 2 weeks after the documented clearance of the candida species from the bloodstream and the resolution of symptoms. And one should also consider, since this is something that we often don't do, stopping of the therapy in about 4 to 5 days if there has been no clinical response, and if it is also associated with a negative cultures at that point of time, and with a low high negative predictive value. One can transit from an echinocandin to fluconazole, or from amphotericin B to fluconazole, which is usually done in about 5 to 7 days in a patient who has become clinically stable, and the culture reveals that the strains are susceptible to fluconazole, and particularly for Candida albicans. If it is Candida glabrata, one could probably transit to a higher dose fluconazole or voriconazole, whichever one would prefer. For voriconazole, one can use 400 milligram twice daily for 2 doses, and then 200 milligram twice daily, which can be used for invasive candidemia, but preferably recommended as a step-down oral therapy rather than as an initial therapy. Coming down to the neutropenic patients in the intensive care, echinocandin again continues to be the recommended therapy. Fluconazole again can be used in patients who are not critically ill and who have not been exposed to azole in the past. Liposomal amphotericin B is not a very attractive, but continues to remain as an alternative because of potential toxicities. And voriconazole again can be used in the initial 2 doses with 400 milligrams, which is about 6 milligrams per kg, and then followed by 200 or 300 milligram twice daily. And this is particularly used in places where one would think in terms of an additional mold coverage. If it is Candida cruzi, any of the echinocandins or lipid formulation of amphotericin B or voriconazole would be used. Going on the neutropenic patients, the recommended minimum duration of therapy for candidemia without any metastatic complication is again 2 weeks after the documented clearance of candida from the bloodstream, provided the neutropenia and the symptoms attributable to candidemia have resolved. Ophthalmological findings of choroidal and vitreal infection are minimal until recovery from the neutropenia. Hence, they should be performed. The ophthalmologic or the dilated fundoscopic examination should ideally be performed within the first week after recovery from neutropenia, not before that. Whereas in the non-neutropenic patient, one should do it within the first week itself. In the neutropenic patient, the sources of candidiasis is not the CVC but other reasons, probably the GI tract. And the catheter removal should probably be considered on an individual basis. And these are the reasons why a lot of these patients may have very low cell counts, whether it is the platelets or deranged coagulopathy, and may not be attributed may not be possible to remove the catheter. And that because in these patients the focus probably lies somewhere else and not in the CVC. In terms of coming down to the cryptococcal disease, this is from the 2010 update by ITSA. In HIV-infected individuals, liposomal amphotericin B becomes the primary therapy, and this should be used in the dose of about 3 to 5 milligrams per kg per day intravenously. In organ transplant recipients for CNS disease, liposomal should be used along with flucytosine in the doses of 100 milligrams per kg per day in 4 divided doses for at least a period of 2 weeks. In non-HIV, non-transplant hosts, if the patient is intolerant to deoxycholate preparation, one should think in terms of the liposomal amphotericin B switching over. And an important aspect, which almost leads to the fact that every second or third patient in the intensive care is exposed to an antifungal, is primarily because somebody has sent the endotracheal aspirate for a fungal smear, and we end up with a fungal smear positive. And that's why the isolation of Candida species from the respiratory tract does not require antifungal therapy unless we have a strong suspicion for a fungal pneumonia. And this should be treated with, and this is a recommendation from the ITSA Guidelines 2016, with a very strong recommendation with a moderate quality of evidence. I've talked about when to stop the empirical therapy. To come down to concluding what happened to our 3 patients. In the first patient who had acute severe necrotizing pancreatitis, she was already on carbapenem glycopeptide along with an azole is what we added at our hospital. The lab reports did suggest 3 days later of a fungal growth, possibly Candida. We did get started, mind you, she was in a shock state at that point of time. We did get started with echinocandin after stopping the azole, but the fungal culture came back as Candida phaumata, and we had to switch over back to a liposomal amphotericin B because that was not so sensitive, and the echinocandin was withdrawn. In our second case, this is a young lady who had a CA tongue in the background, and this was the CT scan with patchy consolidation with soft opacities. The bronchial lavage did suggest a hyphae with fruiting body on the KOH mount, and the transbronchial lung biopsy did show teeming fungal hyphae with branching pattern. So this lady had a CA tongue, which was unevaluated and which was evaluated but not treated, invasive aspergillosis, and of course, if you remember, she had tested positive for H1N1 also. This was way back in 2011 and 12. Our third case was a case of mucormycosis. This is the transbronchial biopsy that we took when she was ventilated. She unfortunately did not survive. The morphology typically suggests that these are the non-septate fungal hyphae with showing 90 degrees branching pattern and morphology conforming to the mucormycosis. To summarize, the empirical antifungal therapy should be initiated as soon as possible in patients with the risk factors present as we elucidated, along with the signs of septic shock and no culture positivity coming across, and the patient continually decreasing. The patient continued to deteriorate gradually. Physicians like us should also evaluate the case by case to case based on the risks and the benefits of the antifungal treatment after considering the treatment timing, the risk factors, the local microbiological epidemiology, particularly in the respective hospitals, the costs, the available biomarkers, if there are any available at our individual hospitals, and the diagnostic microbiology assays that can be available in our institutes. So with that, I hope I've done justice to the topic. I know this is the COVID times. Yes, we've had some incidences of COVID patients going on to develop invasive fungal infection. That's just been hardly a patient or two, particularly in the patients who received tocilizumab. And thankfully, the antibiotic burden has suddenly been going down in the last couple of months. With that, I thank Yash once again and Bharat Serums for giving me this opportunity to come across to you and share some case scenarios and a presentation. Thank you.
Thank you so much. Thank you so much for that presentation, Dr. Mandal. Now we'll move to the last part of the presentation and the symposium before we start taking questions. The last part is actually my journey as a patient by Dr. Gunjan Chanchalani, and she's a chief intensivist at Nanavati Super Speciality Group of Hospitals in Mumbai. I give the presentation to Dr. Gunjan, and here we go.
Thank you, Dr. Charu, and thank you, Dr. Yash, for the opportunity. But I just want to correct here. I am now heading the ICU at Bhatia Hospital. I am no more at Nanavati. Thanks. So thank you, Yash, for this for letting me speak on this, because I did learn a few things as I was a patient while I was admitted as a patient for a COVID. So I learned a few lessons, and retrospectively, I wish I could correct them someday. I mean, I wish nobody else repeats them as I go through this. So my journey as a patient and what I have learned. So first thing which I would tell everybody, that whoever is working in the COVID unit, I have been working in the COVID unit, heading the unit for almost 6 months now. I always assume that I have been already infected and I may have the antibodies. Not that I let my guards down any day. I was always taking all the possible precautions. But one important advice, or at one important point that I have learned, that is, you are not infected unless it is proven. And with a few cases of reinfection coming in, I would say, please stay safe. Please assume that you can anytime get infected, and take all best precautions that you can. The second thing that I want to point out is that COVID-19 is never acquired while you're working in the COVID unit. Because while you're in the COVID unit, you're all in your PPE. You are kind of in a for last 6 months, I'm following an obsessive compulsive disorder while donning and doffing, taking utmost care about myself when I am in the COVID unit. So COVID-19 can never be acquired when you're in the COVID unit. The COVID-19 is actually acquired when you are outside. And we also acquired it when we had to do some emergency travel. And that is when we acquired it as a family. Me, my husband, who's also a frontliner, and me both got it while traveling rather than while working in the COVID unit. So that is the most important point, that when you're in the hospital, when you're not working in the COVID unit, please stay safe, stay away from the colleagues, eat alone, have tea alone, so that you don't spread it further and you don't get infected yourself. Just a second. Sorry. I can't see my screen. Just a second. Yeah, sorry. Okay, so stay safe and stay protected even when you're not in the COVID unit. Next point is, when I go to PubMed, I find lakhs and lakhs of papers on COVID, but I believe that we know nothing about COVID. What I learned all these months, that there are risk factors of COVID which lead to severe illness, and the risk factors were male gender, advanced age, obesity, BMI more than 30, comorbidity, smoking, and many more things. And believe me, I had none of these risk factors. I am a female. I am not very advanced. I don't want to reveal my age, but I'm pretty young as yet. People who know me know that I'm not obese. I have no comorbidities. I have no addictions. But despite that, I did land up into a moderate illness. Not so severe, forbiddenly, but God has been kind with that. But I did land up with a moderate illness despite having no risk factors. The only risk factor probably I had was of being a healthcare worker. And this is where I made a mistake. That is when I got my first symptom. The only symptom probably I had is a little headache and a malaise. And I just thought maybe I'm overworked. For 6 months, we have been working non-stop without a break. And I just took it as overworked. I continued to don and I continued to work for 2 consecutive days despite having those symptoms of malaise and body ache. Not that I required any pills, I did not record any temperature, but I continued to work to realize on the third day that I had a high-grade fever. And probably that is when my viral load went up, and I landed up into a more severe illness is what I'm assuming. But all I would like to say is, as a frontline worker or as a worker who's working in the COVID unit, listen to your body. When you have any symptom, any malaise, please stop and rest. Please give your body some time to rest yourself, to recuperate well before you dawn again. The next thing is why I stayed home. When I got the first fever, of course, I stayed home. I did not get myself tested. Not that I was afraid of any social stigma. I was not afraid of anything. But yes, I was afraid of my little one. I did not want to get admitted, or I did not want that me and my husband both are positive and my daughter is not, and where would she go? So that was one reason why I never got myself tested. And I stayed home, and I stayed pretty long home to get worsened at home and then get admitted. This was a major mistake which I did, and which I think I have learned in a very hard way. But yes, I did postpone testing myself. I continued to rest at home. I did take all precautions. I took all the tablets which so-called COVID treatment guidelines say, vitamin C, zinc, or whatever you can talk of. I hydrated myself well. I would check my temperature every day, multiple times. I would also do my walk test, 5-minute walk test twice a day to find my saturation perfectly fine. But I still stayed home. I still stayed home till my day 9 of illness. Despite me having fever for 9 days, I stayed home. So that was for my little one. But then I retrospectively feel I should not have done that. And then finally the biomarkers. Of course, for 6 days I had fever. Day 4, my fever was very high, and from day 5, I started falling. So I felt I'm in the mild illness. I'm that lucky one who was in the mild illness. And but still, because my well-wishers always wanted me to do some tests, I got my test done. I got my CBC, CRP, D-dimers, ferritin, everything done. And believe me, everything was in the normal range. My CRP was just 5. My NL ratio was 1:1 with 45% of lymphocytes. My IL-6 was 7, and my D-dimer was just 250. So I was with a cutoff of 500. So obviously I assumed I am in the mild illness, and I continued to stay home further. This was my day 8 of the illness and day 6 of my fever. So I assumed I'm in the mild illness, and I was very happy about it. Of course, my pulse oximetry continued to show me a saturation of 99. And this is again where I made a mistake. Probably when I continued to have fever on the day 9th, I decided all my well-wishers called me to the hospital. You just come to the hospital once. And where I reached, and I found my saturation was 94, and my CT scan was rushed in to find a CT score of 8/25. So I would say invest in a good pulse oximetry. I have no advice on this, that what is a good pulse oximetry. I tried Googling which is a good pulse oximetry so that I could invest on it now, at least for my parents or my other family members, but I found nothing. I think every pulse oximetry has a lifespan. I have been having this pulse oximetry for like 6 months now at my home, and I think it has gone in, it had its lifespan, and it never went below 99. To reach to the hospital, I found that it was 94. So if you are in doubt, please go to the hospital and get yourself checked rather than being at home for a longer time, assuming that you have a mild illness, especially if you have symptoms of fever. So when I was admitted finally with this, I was alone in the lone room, and I continued to spike. I continued to remain toxic even on the day 2 of admission. Of course, I was given steroids, I was given remdesivir, but I was alone. And that is when my mind was mad. My mind was not in my control. And this is the worst phase of my life. And I think despite we being warriors, we being on the front line, despite we being prepared to fight our war, we can go through this. This was what I want to mention, that I went through this, and it was like, I wish I would have hugged my child a little longer. I wish I could have told her that, I was thinking of all those patients who came to the hospital with a lower oxygen, promising their families that they would go back, and probably some did not go back. So this was the most mentally taxing for me while I was in the hospital continuing to spike fever for 2 days. But it was kind enough that from the day 3, my fever started dropping down, and my oxygenation also started improving. And the one thing which I realized when I was in that lone room alone, though I was in my own hospital, I knew every person there, right from the clerical staff to the grade 4 workers to the nursing staff. I knew them by name, though they knew me by name. I was having a VIP treatment. But despite that, I did not see a single human face for all those days I was there. All I saw was aliens who were in PPE, who would come and visit me. Of course, they would joke, but that human touch, I lacked that human touch. When I joined medicine, my teachers always taught me, treat the patient, don't treat the disease. And at 6 months after this illness, I feel that we are only treating the disease. We are not treating the patient. We have lost that complete human touch. As we are daily concentrating on winning this deadly virus, we in this process are forgetting what is human touch. While being in that hospital, I did not see a single soul no single soul. I could not see skin except for my own self. I did not see a single skin. People were all covered in PPE. I mean, I missed that touch when somebody would feel my pulse. I would miss that human touch. I would miss that reassuring smile. I would miss that glare in the eyes to tell me, yes, you're going to be all right. So I think that is where I think we should come, that the compassion that today the doctors, when we join as a doctors, we are compassionate, and that is why probably we enter this field, and that is why probably we are in this field. But I think with this COVID era, we have completely forgotten what compassion is. Probably it is the overwork of the pandemic, or whether we are in that PPE, we just want to get out of that PPE. But this is what I feel that we have lost. And of course, this also had a few negative psychological, physiological effects on my own body for the initial days when I was not well. But God has been kind. I have recovered well. And I think human touch is what we need, more compassion when we deal with our patients, because they know nobody there. They are all alone. They are with their families are home, and they don't know if they would go back. So this is one thing which I would request, that everybody is working as a frontliner to get that human touch back, which I think when I join back, I will definitely get it back. And that's all I have to say from my experience. Thank you. Stay safe.
Thank you so much, Dr. Gunjan. It was really nice hearing to your entire experience as a patient and your journey. Thank you. Dr. Yash sir, should we take questions now?
Yeah. We start with the questions.
We have a lot of questions in the past 2 hours of our entire symposium. Some of them have been answered, but I'll be going through them. And Dr. Yash, you please let me know which to answer to by whom. So the first question would be, how do we diagnose COVID sepsis? Is serum procalcitonin is the one which needs to be elevated to diagnose it?
Gunjan, would you like to take the question? Dr. Gunjan?
Serum procalcitonin has nothing to do with COVID sepsis per se. So serum procalcitonin probably would give us an idea if there's a secondary bacterial sepsis, but then COVID sepsis is a different entity altogether. It is more of the clinical or hemodynamic correlation that you need to have before call it a COVID sepsis. I mean, sepsis is what? Sepsis is now defined as dysregulated immune response. I mean, COVID, the bad effects or the severe effects of COVID that we are seeing is because of the dysregulated immune response that we have. So COVID itself is a sepsis, but procalcitonin is not the diagnostic for that. Neither a parameter to rule it out.
Okay. Dr. Harish, we have a question saying, what is the cut down value of D-dimer for prophylactic and therapeutic anticoagulation in terms of COVID-19?
This is one thing we need to understand. So suppose if you get a D-dimer value of more than 250, you go for something prophylactic, and if it is more than 1000, go for therapeutic kind of this one. But don't give any weightage to that value cutoff kind of this one. So you see how bad is the patient in terms of overall inflammation, because one thing we need to understand, D-dimer is also one of the acute phase reactant. So hand in hand, when a patient had some sort of procoagulant behavior, is other inflammatory markers what we currently practice, maybe ferritin, LDH, C-reactive protein, other acute phase reactant should also jump kind of this one. Suppose my understanding, okay, you have a cutoff of 250. So then if the patient is having a 251, you need to give the prophylactic, or if the patient is having 236, 238, you don't give the prophylactic kind of this one. So maybe prophylaxis is well accepted, but don't jump on going for the therapeutic for all the patients. Keep a bit of threshold for that. Don't, okay, all the patients who are on, all the patients who are on the floor, definitely they get therapeutic, that's not the dictum, but they should get the prophylactic as like that of other patients kind of this one.
Sure. Dr. Yash sir, would you like to add something to this?
No, I think everything has been answered by Dr. Harish. As he rightly pointed out, it is not only the marker of prothrombotic state, but also a marker of inflammation. So if the inflammation is bad, or there is thrombosis, both conditions your anticoagulation should increase in dose. And if persistently high D dimers are there despite the highest dose of low molecular weight heparin, then you have to increase the dose. Anyways, all the severely ill patients should be having maximum dose of low molecular weight heparin for that particular clinical context.
Can I add one
We
thing?
actually received a lot of questions on ulinastatin, but most of them have been answered in detail during our presentation. I would like to take one very important question, and I would like Dr. Shashidharan to take this question. What exactly is the role of plasma in arresting the progression of pneumonia in COVID-19? And if there is, then when do you prescribe plasma, and what exactly is the dose of convalescent plasma which you give to the patients?
So, I mean, it's a very interesting question of which the answer is probably now very controversial and very doubtful as of now. But if it's okay with you, could I just answer that question on D-dimer before this, because I think it's very important that I give my view there.
Please do. Please do.
So I am doing thromboelastography in almost every patient that gets into the ICU, and what I have noticed is 40 to 45% of patients do have a very low RNK values and very high angles and MAs, indicating that almost 40 to 50% have got an extremely hypercoagulable state, and I followed that up to their home for the next 3 weeks too, and it does look like for a good 40 to 50 days that hypercoagulable state does maintain. So I would not look at D-dimer to actually titrate my dose of anticoagulation in any way. In fact, if the patient every patient that enters into the ICU does get prophylaxis by way of anticoagulants. But if he demonstrates a sign of pulmonary embolism or venous thromboembolism of any nature, that is when he gets onto therapeutic. See, I strongly believe we should do things only what is there in literature, and I don't think we should do anything beyond that. D-dimer going up doesn't signify titration. I've seen this many times that if it's D-dimer is thousands, 2000s, like that's anecdotal evidence that came out from the Mass Gen University, which said 1000 and 1200 and more than 2000. Anecdotal evidence. There's no evidence that says that it determines the thrombus load. In fact, there have been studies that have looked at 8,000 D-dimer units and absolutely no thrombosis anywhere in the body demonstrated by angiography. So that's why D-dimer was always a negative cutoff. It was never, and that also in the patients with the lowest probability. So that is the reason that we never thought about D-dimer as diagnostic or titration for anticoagulation. That's one part of the story. And the other part of the story was about plasma. I really don't know what's happening with plasma, but I do notice from my experience that I would have treated probably around 60-70 plasmas. That's the only much lesser than what probably Ansari would have done. But I didn't. So around 70 to 80 patients is what I would have given plasma. What I've noticed is when I give it early, it looks like the lymphocyte starts moving up. Now, whether that is related to the plasma or whether it is related to so many other things we are doing together, I'm not very certain what's happening. But it has probably just helped me this way that it is not creating any side effect. Since I'm not seeing any major side effect on plasma, I'm erring on the safer side by giving plasma early if the patient comes quite early in the disease. And the dose is 200 is what I'm giving. I'm not giving more than that, because what I've noticed is when I'm giving more plasma, I did have an episode of Trali in one of my patients. So I don't know whether it was dose related, but I'm giving only 200 ml, and that's and the guidelines do say 200, and then the second dose of 200 if the patient doesn't improve. That's what the guidelines say as per the Indian Thrombohemostasis Society or Hemovigilance Society.
Can I add?
Dr. Ansari, would you like to add anything on this?
Yeah. So
Dr. Mishra, please go ahead.
Sorry. Dr. Harish, you wanted to say something? Dr. Mishra, you wanted to say something. Should I take this?
I wanted to just add a little bit on plasma.
Please, sir.
Actually, we have data of more than 300 patients where we have used plasma, and most of the time, as Dr. Sanjay told, we have used only 200 ml once, but we have used twice and thrice also in few cases. And we have seen like mild to moderate disease, when we have used plasma, there is some significant improvement in oxygenation and hemodynamic parameters also. Irrespective of whatever the Placid trial told, but we have seen significant improvement. We have the data, maybe we will be publishing, and plasma is helping. And regarding this D-dimer also, one more typical thing what we have seen is like the people having D-dimer, even if the number is not important, If the D-dimer is more than 10,000 persistently, those people are not doing well. And we have seen low molecular weight heparin somehow is not working well. If you give low molecular weight heparin, even 7,500 fragment twice a day, also the D-dimers are not coming down. We have seen heparin helping, IV heparin that too, with a regular epidemiology check. And somehow maybe I cannot prove it, or there is no literature right now. Once the D-dimer is, the trend is in the improving, the patient also improves. And the person's D-dimer, whom D-dimer is never improving, it is persistently more than 10,000, 8,000 like that, they're not doing well. And a lot of people we have lost. The two most important inflammatory parameters what we have seen over the time of last 3-4 months in this maybe around 600, 700 patient, ICU patient what we have seen. The two most important thing, one is CRP, second is D-dimer. If CRP is very high and D-dimer is very high, those people are not doing well. These are the sickest group of people. Even if initially they are presenting not that sick, they are going down very fast. Apart from IL-6, I believe they are the two most important parameters what we need to see in all cases will be CRP, D-dimer.
Definitely, Dr. Mishra, see, that is the key here. So all the CRP and D-dimer particularly may not be suggestive of thrombotic event alone. It is a general prognostic indicator. But the question is, so suppose we target that general prognostic with the like heparin alone, or in any sort of anticoagulation alone, that will improve the outcome. That is the question. So maybe like we have to wait for some like therapeutic approaches. They directly correlate.
Sure that subcutaneously when we are giving a low molecular weight heparin, is it reaching the therapeutic level? How is the absorption and all those things? So maybe that I'm not very sure. Like you see, like if the only thing what you can differentiate between a unfractionated heparin given IV and a low molecular weight heparin given subcutaneously, is there any problem in absorption when you give subcutaneously?
Yeah, but see, basic our pharmacology understanding when it comes to unfractionated heparin, that is the one which confuses PKPD, because it's having a non-anticoagulant targets like plasma protein, like endothelial attachment and all. So the predictiveness of PKPD and the effectiveness as compared to low molecular weight heparin versus the unfractionated heparin, definitely good with the low molecular weight heparin. So that is our this one. But the problem is, like targeting this D-dimer with the heparin is standalone going to improve the outcome. So it's very difficult to tell kind of this.
There is nothing standalone at this point of time.
Yeah.
No patient will be on one drug, no, at this point of time. There will be multiple drugs going on. And to say that this drug is helping or that drug is helping is again very difficult at this point of time. You have to see maybe like there is a sudden improvement or sudden deterioration.
But my question is, Dr. Mishra, how much you are giving as a therapeutic and what target you are considering when you give a IV heparin kind of this one? You see the APTT.
Yeah, no. Somebody who is sick and the D-dimer is, let's say, more than 3,000, 4,000, we are directly starting off unfractionated heparin IV, and we are checking APTT as per the protocol, like maybe 6th hourly or 4th hourly.
And you load them with the heparin or just like?
Yeah, we load and we start infusion and we target APTT.
So your cutoff for D-dimer for starting an IV unfractionated heparin is 3,000, and you load and you maintain
Not
the
like
APTT.
3,000 or 4,000, maybe the sickness patient is sick with a higher D-dimer, will you start off unfractionated heparin infusion?
Okay. Just wanted to, in addition about what discussion going on, the role of thrombolysis, as Dr. Sanjit was mentioning about the thromboelastography, what the people discussing about giving heparin. The thrombolysis, if the showing hypercoagulable state, if you are on the highest dose of the heparin along with the single antiplatelet, we use thrombolysis with altiplase, half dose, not full dose. That also shows a lot of clinical improvement in the oxygenation of the patient.
I think we have to end at 5:30. So I'd like to just summarize. I'd like to thank everyone. I'd like to thank Dr. Ansari and Dr. Rangappa. Dr. Rangappa's father-in-law is unwell, so he could not be with us. I'd like to thank our esteemed panelists, Dr. Madhusudan, Harish, K.C. Mishra, Dr. Sanjeet, Dr. Amit Mandal, and Dr. Gunjan Chanchalani for his very, very touching presentation. And we had a very good learning from your talk, Dr. Gunjan. I'd also like to thank Dr. Charu Dutt. I'll hand over to Bharat Serum people for their vote of thanks. Over to you, Bharat Serum.
Dr. Ravi.
Thanks, Dr. Yash, for this enlightening session and webinar, and also all the panelists and speaker has shared their views. And I'm sure that with today's discussion, there will be very good treatment for the patient in this testing time. So once again, I thank all the speakers, Dr. Sanjeev, Dr. Jaju, Dr. Mishra, Dr. Amit Mandal, despite he was busy in his daily schedule, and there was more need for he to be in ICU. So he shared with us his presentation, which was recorded, but it was very helpful. Also thank Dr. Gunjan, and I also thank all the participants who participated and attended this symposium, and looking forward that there will be more meaningful engagement with all the eminent speakers, and special thanks to Dr. Abdul Ansari as well. He is one of the and all the speakers, they have shared their feedback and their experiences. In future, BSVL, that is Bharat Serums and Vaccines Limited, will like to be associated with the medical fraternity for more such scientific interactions. And once again, I also thank all the attendees who has taken time from their busy schedule, attended this webinar and symposium. So with kind permission of all the speakers and host, I will like to hand over this forum to Dr. Yash for final comments and closure.
Thank you, Dr. Ravi. I'd like to thank you all again, and probably we have 3 major lessons. One, we have to follow the trident approach: early antiviral, early remdesivir, steroids only if there is resting hypoxia, not otherwise. Please do not prescribe steroids for patients who are not having any hypoxia, resting hypoxia. The dose is generally 10 days, could be prolonged based on clinical information, but the standard dose is 6 milligram for 10 days. And the third part is thromboimmunomodulation. Most patients are having a very, very high risk or of prothrombotic state. So try to give the maximum dose of heparin or low molecular weight heparin for that clinical context. If it is a patient who has a brain trauma injury, then obviously you have to titrate your dose accordingly. Thromboimmunomodulation, steroids if there is hypoxia, and third is organ support. We start with nasal prongs and then go on to HFNO or NIV and then mechanical ventilation. So these are the major learnings. Second major learning is from Dr. Gunjan's talk, that you have to always be very, very empathetic. Don't lose the basic touch and be very, very kind and loving to your patients. It is more of your feelings which probably cure the patient rather than the treatment, and a kind act, a kind smile works more than any other important drug. So always be empathetic and have that human touch in your treatment. Thank you all. Thanks for sharing your valuable.
Thank you. Thank you.
Thank you so much, sir. Thank you, everyone.
Thanks, Dr. Harif, and thanks to the panelists and then moderator as well. Thanks.
Thank you all.
Yeah, everybody, we will close the session now. Sandeep?
Yeah. Thank you everybody.
Thank you, everybody.
I'm closing the session now. Thank you.
Please do.